Good evening to everyone, and congrats to everyone who have cleared the theory. I think that is one of the biggest barriers that you've cleared. So, regarding critical care, if you have cleared your theory, usually the practicals is relatively easy to pass because the pass rate relating to critical care is good compared to the other super specialties. So, without further delay, we'll go into my discussions. So, I'll be concentrating on critical appraisal of a research paper and I'll be talking about ECGs. So, for critical appraisal, I'll be concentrating on what is needed from a practical point of view. I'm not going to go in depth of how you really do it in real practice. That will not be applicable. But what is necessary for our exams is what I'm going to concentrate on. And for ECGs, it will be more like a one-to-one discussion so that it will be interactive and we'll be able to finish it faster and we'll also be able to gain more knowledge also. So, uh, just the basics related to critical appraisal of a research paper. Usually in the exam, they will give you this research paper about like 15 to 20 minutes after your long cases and short cases are over. So that is during the lunch break will be the actual time when you will get to prepare your prepare meaning you will be able to go through your research paper. So you need to be very focused on what all areas you need to cover. So the number one golden rule for a practical exam in relation to critical appraisal, please do not read the abstract in front of the examiner. That will create a really bad impression. And after that, he will not be very interested on asking further questions because the abstract is just like a summary. Like if you're looking through your Instagram, you're seeing through the reels, right? That they may show that reels for about 1 to 3 seconds, like a just like a snap view. So that is what the abstract is actually is about. What you really need to go through is from the introduction point of view. So that's where the main contents are, and that's where you need to really focus. So, rule 101 is please don't read the abstract in front of the examiner when you're starting a critical appraisal. So, the next thing is underline the significant findings and keep it in your view when you present to the examiner because you will already be thoroughly stressed out. So when you read through the research paper and you have all the points in your mind, you just keep it underlined so that when the examiner asks, you just point out and read those points which you have underlined alone. So those will be in a systematic manner so that you don't miss anything and it will also impress the examiner. So like Darshana told, in relation to critical care appraisal, the ultimate thing they will ask in the end is whether you will use it in your real life practice. So the way you have to identify that is by looking for any bias in the study. So the more number of biases that you can identify, the less valid it is going to be. So that kind of in that way you can say that you will not use it. For example, for me, I got prone ECMO study for my practicals. So I read through that. It was an open label study, and there were multiple flaws in it. So then towards the end, he had asked me whether you will implement it in your routine practice. I told no, I will not implement it. And I gave him the reasons like 1, 2, 3, 4, 5. So he was okay with it and he told good indeed. So that is what they will expect at the end. In case you say that you will use it for in your practice, then you will have to justify your reasons for that. So that is what they will mainly expect. So we'll have a PPT discussion and then I will just show you one study like how to go through it so that we'll have a clarity about critical appraisal from a practical perspective. So the main areas I'll be covering is the introduction and analyzing a research paper. So why is critical appraisal important? So we'll just take a small example. So we have a doctor 1, 2, 3 who reads the latest issue of a journal. So he had read that in a randomized controlled trial on a new treatment had actually caught his eye. So the results showed that the new treatment was better than a placebo tablet and it had helped patients to improve faster and with fewer side effects. So the authors of the article recommended the new treatment as a first line intervention. So without a further thought, this doctor was convinced that his patients would benefit. The problem was he had just read the abstract without reading the inner contents of it. So he expected to achieve better outcomes than his colleagues, and with the next day itself, he started prescribing this new medication to his patients. So we'll come to the next part of the story towards the end, like once we read through the full topic. So the main areas I'll be covering is the concept of evidence-based medicine. Why do we need to critically analyze a study and the elements of a critical appraisal? So the concept of evidence-based medicine. So what is it? It's just a phrase that is used to describe the process of making clinical decisions about a patient's clinical state, considering three things. One is the best evidence that is available, then our clinical expertise and the patient preferences. So based on these three, the foundation for evidence-based medicine is made. So what are the components of it? There are five steps. One is the question, the evidence, the critical appraisal, the application, and the monitoring. So question is you formulate a precise structural clinical question about an aspect of patient management. Okay. So you, like example, you in septic shock, you just so, like I said, the concept of evidence-based medicine, you look into three things: the best available research evidence, the clinical expertise, and the patient preferences. So, the main steps of evidence-based medicine is question, evidence, critical appraisal, application, and monitoring. So, the question is you formulate a precise structural question about an aspect of patient management, like use of steroids in sepsis or septic shock. Then you gather the evidence around it. Then you critically appraise it. That is, you look into the study, like you look into the adrenal study, and you see the results, and you apply that intervention of that study to your patients and see. And then you assess whether it is having the same effectiveness as what it had for the patients. So this is the actual concept of evidence-based medicine. But what is important for us is to look into the critical appraisal part of it. That is more important for us, for our practice. So what we need to do is evaluate the evidence, critically analyze the evidence for its validity, impact, and applicability. So this is what we need to look into. So what is the main definition of appraisal? The act of assessing something or someone. So why do we need to critically analyze the study? Number one, to detect bias and to understand the significance and magnitude of the study, to assess whether knowledge study can be applied to patients. Because study is going to be full of errors. It is going to realistic results. It is result in your practice. So then that the study has been
Sir,
shown.
sorry
Like
for the
example,
interruption.
used.
Excuse me, sir.
Yes.
Your voice is breaking
Yes. Yes.
in between, sir.
Oh, is it one thing? I'll just see.
Please check once your network connection, sir.
Yeah. Apologize for the bad networks. So, just to go through again, why do we need to bias? So, understand, right? Okay. So, really, sorry. So, we will go back into the discussion. So, why do we need to critically analyze a study? Is one, to detect bias and error, because that will cause interruption in your internal validity. So that I'll be discussing subsequently, and to understand the significance and magnitude of the study, and to assess whether the knowledge from the study can be applied to your patients. So what are the five elements of a critical appraisal? The first thing is, what is the research question? What is the design of the study? Assess the study's applicability. So these are the main areas that you need to look into. So how you can do that? The first thing is, in the exam, if at all you're going to look into the research paper, always look into your PICO. That is the population, the intervention, the comparison, and the outcome. So usually these details will be present after the introduction paragraph. So once you do this itself, you will be able to organize the first part of your appraisal. The other thing that you need to keep in mind is, for outcome, there will always be a primary outcome and secondary outcome. So it is important to look into both of them. For example, in most of the steroid trials in septic shock, they would have always mentioned the primary outcome in relation to mortality. But the secondary outcome will be in relation to resolution of vasopressors. That will be very much significant. So those details you need to mention in your being asked. So it is very important to look for what the outcomes are and if it will be relevant to your practice. That is your generalized applicability. So what is the study of the design? So for the exam, most of the time RCTs only will be kept. The rest of the types of studies will not be there. It will be more of RCTs only. So you need to concentrate more on those areas. So if at all they ask you about the level of evidence, the best evidence, as you all know, is for systemic reviews and meta-analysis, and the poorest is for editorials and expert opinions. So why this is important is at the top of the pyramid, the risk of bias is very, very low. Whereas at the bottom, the risk of bias is the highest. So RCTs come at the second. So that is why if it is a well conducted study, usually the risk of bias is less. So you need to look into how the study has been done, whether there is bias. That is what I really want to emphasize. So when you look into the research paper, keep looking for any mistakes that have been done or something that is being out of protocol. So that you can mention to the examiner and that will add value to your marks. So coming to say, higher the quality of evidence and lower the risk of bias, better the validity and applicability of the study to the general population. So the best study depends on the type of question. This is just for general knowledge. So for assessment of which therapy is better, generally a randomized control trial is ideal. For a diagnostic test assessment, usually a prospective cohort would be ideal. But for, again, like I said, for an RCT, RCTs are usually the ones that will be asked in the exams. So like I said, a poorly conducted study usually tends to overestimate the effect of an intervention. So assess the study's validity. That's the next part of it. So you look into the research question, then you look into the study's validity. Was the study conducted so that the results are true for the sample that was studied? So the main thing you need to look over here is for searching for bias. So bias, most of you would know about it. They are mistakes that don't occur because of chance, but due to mistakes in the research study. So it leads to erroneous conclusions as a result of differences between groups that are simply not due to chance or exposure of interest. So when interventions are applied based on these conclusions, it can lead to harming patients. So that is why it is very important to critically appraise it, because based on the data that is being provided, if it is not properly assessed and if there are a lot of mistakes in it, ultimately your patients may be harmed. So like I said, bias overestimates the effects. So when you critically analyze a paper, always and always look for bias. That is your one of the primary goals that you need to do. So types of bias and the ways it can be avoided. Coming to the types of bias, the first type of bias that we need to know is the sampling bias or the selection bias. So it is caused by non-randomization, leading to biased selection of participants for a study. Example, volunteering subjects may not represent the study population. Example, if you are taking studies for like a drug study and you take healthy volunteers, that may not represent the true population of those who actually may need that drug for their purpose. Example, you have found a new oral oral hypoglycemic agent for diabetes. The problem is initial volunteers who come for it may be normal subjects. So if you give it to them and you expect a response, that cannot be applied to the general population. So that is what is they have emphasized over here. So the important thing is randomization is important. So if you see a study and you see that it is not randomized, you can be well assured that there is going to be a high chance of bias in that study, and the internal validity is going to be very much affected. So it is usually seen with case control studies and retrospective cohort studies, all the studies that go in a backward manner. And sampling bias can be avoided just by randomization. So there are four types of randomization. In that, stratified random sampling is considered the best form of randomization. So if you have a study that has this kind of randomization that is done, then you can be well assured that the randomization is good. So the conclusion of the slide is you check if the study has been randomized. If it is not, then there is an increased risk of bias. So coming to the second bias that can be that is called the recall bias. So it's a systemic error that can occur when participants don't recall previous events or omit details. So the problem here is there may be studies where you would have recruited a lot of patients and the timeline of the study may be very significantly high. So the problem is you may have enrolled the patient 1 year ago, and when you go and talk to that patient and ask them the details of what had happened at that point of time, they may not be able to remember the real issues. So when you ask subjective questions, they may not be able to elicit most of them properly. So that can lead to this thing called recall bias. So there are two ways of avoiding it. One, you reduce the time lapse between the events and the data collection. That is, once the enrollment is being done, you as quick as possible, you go to those patients, you assess and collect the data. The second thing is you use objective measures whenever possible rather than using subjective measures. Example, in most of your neuro related trials, they would have used the modified Rankin scale as a marker of neurological outcomes. That is a good objective tool. So if you see in most of the studies, they will be using modified Rankin as their main objective score to assess neurological outcome either at 6 months or 3 months. And accordingly, they interpret the final results. So the conclusion to this slide is if the subjective measures are used rather than objective measures, or there is an increased timeline between the data collection and enrollment, then there is a very, very high risk of bias that can occur. So we have seen about sampling bias and we've seen about recall bias. So sampling bias can be avoided by the use of randomization, and recall bias can be avoided by decreasing the time period between the sample enrollment and data collection and using objective tests. So in the study itself, most of the places they would have mentioned about the objective tools that are they have used for assessing the outcomes. So the next one is observer or Hawthorne bias. So usually in most of the ICU patients, most of them would be intubated. So this would not be much of a problem. But in other scenarios, there may be instances where the patient may change his behavior when he is being observed by a interventionalist. So when they change their behavior, it will provide a different perspective to your data. So that may create a bias. The best example, what they say is like when you're sitting in a classroom, when there is no one to supervise, our behavior will be totally different. But when there is a teacher or a senior person who comes into the class and who keeps observing you, your mannerisms totally change. So that change may create a total change in the effect of your data. So that is called as Hawthorne bias. The importance is it may threaten the generalizability to the general population because at that moment of time when they change their behavior or change their attitude, the data that is being collected is going to be different. So that may not be representative of the true population. So that can be avoided by single blinding. So if at all you are able to do a single blinding, you can avoid this observer or Hawthorne bias. So the next thing is, in conclusion, is if check if single blinding has been done in your study protocol. If not, again there is an increased risk of bias. Then you look for interviewer or expectancy bias. So occurs when the physician knows which patients are in the treatment and the control group. So that will give an impression to the physician to draw results based on the intervention that is being applied. So if at all they feel that they have read about some retrospective studies showing that steroids have been very beneficial in septic shock, and now a randomized trial is being conducted and he is aware of it. he may be favoring the use of steroids in those subset of patients. So that itself can lead to a possible bias. So that can be avoided by double blinding. So the conclusion here is you check if double blinding has been done. If it is not done, then can be associated with an increased risk of bias. So the next one is proficiency or intervention bias. That is, there can be an issue when intervention is not uniformly performed to all the study subjects due to a difference in skill, training, and resources, leading to different inferences in different participants. The best example is now a lot of studies are being done on VEXs and renal resistive index. So to get a proper Doppler view of the arcuate arteries and veins, you need expertise. So if one person alone keeps doing it regularly and he is being appointed in the study to perform it, the results will be uniform and it will produce good outcomes in relation to your study. But if you make 10 people do the same thing and all 10 people don't have the same level of expertise, each one is going to produce a different kind of result. And that is going to affect your overall outcome. So that is what is meant by proficiency or intervention bias. So that can be avoided by performing a pilot study first. So you evaluate if different people can produce the similar results, and based on that, you can then plan your main study. So always in your research paper that is provided, you assess if there is a pilot study that has been done previously, and if the interventional group has very few number of people who perform the study. If that is so, then it is going to be a good validity. If not, if there is no previous pilot study that was done, or there are multiple people who have been performing this, then there is a very high risk of bias that can occur. Then transfer bias. There can be unequal loss of follow-up between cases and controls, and exclusion or attrition bias that can be seen in per protocol analysis. So the main thing over here I want to emphasize is you need to know whether the study has mentioned about intention to treat analysis or per protocol analysis. So I think most of you know what is intention to treat analysis. You have 100 patients who have been randomized and you assess the effect of an intervention in those 100 patients. So you see that among those patients, a few patients have lost to follow up. In intention to treat analysis, the people who have been studied and the people who have lost to follow up will be included, because that will be representative of a real life scenario, because that is what happens even in our ICUs on a regular basis. Whereas in per protocol analysis, the problem is once you've randomized and there are patients who have lost to follow up, that is, example, like a 20-day mortality following use of steroids and septic shock, the patient might have been discharged after 14 days from your ICU or from the hospital. The next 14 days, if they have not responded to you or you're not able to reach them, those subset of patients will be excluded from your per protocol analysis. So that will lead to an exclusion, possibility of an exclusion bias. So you always need to see in the study whether intention to treat analysis is mentioned or per protocol analysis is mentioned. If intention to treat analysis is present, it is representative of your generalized population or generalized care, what is routinely seen. So that is a better choice than per protocol analysis. So are the slides visible so far? I just wanted to just confirm it once.
Yes, sir. Visible, sir.
Okay. So there is no break in the voice so far, right?
No, sir.
Okay. So among all that I had spoken so far, I'm just going to summarize all of this. So this is just for a good remembrance. So you can divide the study into two parts. One is the study design and during the clinical trial. So during the study design, there is a possibility of sampling or selection bias that can be avoided by randomization. And I had specifically told you go with stratified random sampling, that is considered the best. If you ask if there is a second best or there's something little that is little inferior but it's still okay, is block randomization. Then you have bias during the clinical trial. Like I said, you can have observer bias that can be avoided by use of single blinding, interviewer bias that can be avoided by double blinding, recall bias that can be avoided by use of objective measures, interventional bias that can be avoided by use of a pilot study and keeping minimal number of people performing the intervention. And for exclusion bias, always look if intention to treat analysis has been done. And for transfer bias, assess for homogeneity in the distribution between the cases and the controls. So if you see that, especially in crossover trials, sometimes when you are related to your ECMO trials, number of patients in the intervention group than the control group. That itself can lead to a possible bias. So I think hopefully everyone would have understood about it. So these, if you want, you can take a snapshot of it. These are the main areas you need to look into the study from a bias perspective. So if you find any of these are there, then that is going to affect your internal validity to a great extent. So you've assessed for bias or error. So the next thing is you assess the study results. So you can divide it into two parts. One is the descriptive statistics and the inferential statistics. So the descriptive statistics are related to those who are in the study, and the comparative statistics are how the groups were compared. That is the tables that were used or any kind of charts that were used, the standard deviations, the p-values, the confidence intervals. And if number needed to treat is mentioned in your study, please emphasize them as much as possible, because it's a very important terminology and it has a lot of clinical significance.
So you're not.
So P value not audible. Now is it okay or?
Yes, sir. Is it okay, sir? But previous slide now, from last onwards, you are not audible, sir.
Okay, I'll just repeat that again then. So you have descriptive statistics and comparative statistics. So descriptive, I've told, those who are in the study will be considered. Whereas in comparative, you will be assessing the tables and graphs, the standard deviations, the confidence intervals, the p-value, and you will also be assessing the people who come under the number needed to treat. So if your study has number needed to treat mentioned, please emphasize it as much as possible to your examiner, because it's a very, very important number and it has a lot of clinical and research related significance. So p-value, as you all know, it shows only statistical significance. It does not have any clinical significance. So that needs to be very much kept in mind. So example, in a data set, there may be statistical significant association between patients whose name starts with the letter A and death due to myocardial infarction. But that does not have any clinical significance. So that is the importance of what I just wanted to say. So the next thing is related to standard deviation. So under standard deviation, you need to know what is mean, variance, and standard deviation. So I'm just going through these just to refresh your memory. So mean is just the sum of all values by the total number of values. So variance shows the dispersion of values around the mean. So assume that the mean is in the middle. All the values that are associated will be dispersed around it. So standard deviation explains how much the values are scattered around the mean. So variance just shows the values are around the mean, but the standard deviation explains how much. So that gives better quantification. So it's, as you all know, it's just the square root of variance. And why is it important is you have a bell-shaped curve for the assessing the distribution of data. So that extent of that bell-shaped curve is dependent on your standard deviation. The greater the standard deviation, that is, you have 1 standard deviation, 2 standard deviation, and 3 standard deviation, the more higher, the greater the spread. So I think all of you are aware of this diagram. So this is during a normal distribution. Usually what we check is for 2 standard deviations. That is, at least the data that we have collected will be within 95% of the standard deviations that being assessed for. So why this is important is for this, the confidence intervals. So just brushing through this, it is range of values which most likely to contain the population parameter like a mean. So it is expressed as a percentage like 66 percentage, 95 percentage, 99 percentage, etc. So the percentage is related to how much the probability that the mean obtained from the study is likely to be the real mean. That is, within that distribution, the mean is going to be present. That is, it is not going to be in that 5% that is being left out. So that is where the confidence intervals play a role. So for example, a 95% confidence interval is a range of values that you can be 95% certain to contain the real mean of the population. I hope everyone had an idea about this. Okay. So as the sample size increases, the range will narrow and the precision increases. So the conclusion is the smaller the confidence intervals, the better the precision and better the internal validity. So you have a higher sample size, the confidence limits comes down and the precision improves. So this is the main conclusion I want you guys to keep in mind. So how do you interpret it? So when you compare two groups, if the confidence intervals do not overlap, then that is equivalent to a significant result. Whereas if they overlap, then there is a insignificance. So the next question that can be possibly asked, especially if it is
Sorry,
related to
sir,
it.
your voice is again breaking
Okay.
from this slide.
Okay. For the previous slide, or is it previous slide? Is it? Okay. So for interpreting the confidence interval, now is it okay?
Yes, sir.
Okay. So when interpreting two groups, if the confidence intervals do not overlap, then that is equivalent to a significant result. Conversely, if they overlap, then it is considered as insignificant. That is almost equivalent to a p-value more than 0.05. So the next thing is to assess which is better, whether a p-value is better or a confidence interval is better. Both can indicate statistical significance, but the p-value just tells you whether it is significant or insignificant. That's all. Whether it is 0.04 or 0.001, it won't make much of a difference. But the confidence interval can indicate the magnitude of an effect and the clinical implications that can be there because of the range of difference that can occur because of this difference. So, more easier to say, p-value just tells yes or no, like a binary. Whereas confidence interval can quantify the significance of the difference. I hope that makes it very clear. So this is very, very important, and this is one thing you really need to keep in mind. So the number needed to treat. So the number needed to treat is the number of patients you need to treat for an additional patient to have a positive outcome. So this will be invariably asked. So I personally would recommend everyone to remember the definition. So NNT is the number of patients you need to treat for an additional patient to have a positive outcome. It is a useful way to summarize the clinical effectiveness of a treatment assessed by binary outcomes, that is yes or no. So there is no specific cutoff value for an NNT. The basic formula is 1 by absolute risk ratio. But what they say is the lesser the number needed to treat, the more effective the treatment. That is, if the number needed to treat is 1 or 2, they say that the intervention is going to be very, very effective. Whereas if it is around 100 or 150 or so, then it is very less likely that the intervention is going to be effective. So that needs to be kept in mind. So the next thing is you assess the study's applicability. It's been good enough to answer the clinical question. That is also called as the internal validity. So if the study has a poor internal validity, we may have unrealistic expectations of the outcomes. So this is what I had emphasized. You always need to assess whether a randomization has been done, whether adequate blinding, whether it is Ideally, a triple blinding is the best thing, but at least if double blinding has been done, it is important. You assess for proficiency bias, any other form of issues that can be there, any exclusion bias that is there. So all these need to be looked into, and you also need to look into the whether the division of splitting of samples between the intervention and the controls are almost equal or equivalent, so that there is no transfer bias. So all these need to be kept in mind. So if you find there is any disparity in any of this, there is a high chance that the internal validity is going to be affected. And because of that, the overall outcomes is going to be very much spurious, meaning it's going to be false data. And to what extent can the results from the study be generalized to a wider population? That is called the external validity. So we want to know whether we will get the same results if it is used in a real life setting. So example, there have been studies in CLD patients where you use 20% or 25% albumin and it has shown to help in reducing mortality. But if you see the subset of patients, it is related exclusively to patients with CLD. You cannot be using that for all other patients because the results are not going to be the same. So that is what is meant by the external validity. So when you read the study population is very important. That's why you need to look into PICO. So when you look in the population itself, you will have an idea which subset of patients they are reading about. So in most scenarios, it will be similar to the ones you are also seeing. So it won't be much of a problem. But there may be certain instances where they may predominantly look into oncological patients or patients with cirrhosis. So those subset of patients, when they use an intervention, that cannot be generalized towards other subset of patients. So that is what needs to be kept in mind. So what I really wanted to say is, do the subjects studied look like my patients whom I routinely see, and does the outcome really matter? So just coming to the first question, first small story that I had spoken about. So the randomized trial caught the physician's eye, so he wanted to use that intervention for his patients because they had told that it was recommended as a first line intervention, but he had only read the abstract. So he began to use it on all his patients. But 1 month later, he was called to the office of the medical director, and they found that the analysis of prescribing costs in his department were very high than his colleagues, and it did not show any good results. So, looking into the study, the medical director had identified various pitfalls in the study that did not reciprocate into real life scenarios. So, following which he was told to abandon the medication he was using for his patients. So, I think this story might give you an understanding of why it is important to critically analyze the paper. So you always need to look into biases. You always need to look into the distribution of data, whether the statistical significance has been appropriately done. And you always need to assess the external validity, whether it can be applied to your subset of patients. So this is the gist of what I had told. And from an exam perspective, this is what is needed. First is the PICO format. If you have a T, it also needs to be applied. That is population, intervention, comparison, and outcome, and along with that, the time frame of the study. So that also, if it is applicable, that needs to be mentioned. And the factors that need to be looked into. That is the allocation, that the randomization that has been done. If preferably stratified, if not, at least block randomization should be there. Then assess if blinding is done. Ideally, a double blind study needs to be done. Triple blind, way better. But if no blinding is being done, you need to be very, very cautious about implementing it in your real life scenarios. Then follow up of patients. Because exclusion bias is high likely, always assess the intention to treat analysis has been mentioned. And in the algorithm flowchart about the distribution of cases, the intervention and the control group, always assess whether the distribution of the caseload in both the groups are almost equal. Because in some, there may be a lot of patients who might be excluded in the other group, there may be very few. So that may lead to a big bias when you do the final analysis. So that also needs to be kept in mind. The next is about the presentation of results, whether it is very precise and clear, whether the tables, the division of all the cases and controls are all equal for all populations, male, female, comorbidities, the severity of diseases that they have, etc., and whether you can apply it to your local population. So this thing needs to be kept in mind when you practice your critical appraisal. So this is the main slide I want all of you to look into, and the other slide is about the slide on bias. So these are the two slides I really need you guys to have it like a take-home message. So the next thing is about what must you know about your thesis work and how to uh, prepare to answer anything related to your thesis. So I think most of you are already been primed about this, but from my side, I'll just say what is really needed. Number one, please memorize the title of your thesis, because the exam and that stress, you will like try to read the thesis heading from the book that is in front of the examiner. That will create a really bad impression, and then he will be tempted to ask more questions and decrease your morale. So the number one thing is always remember the title of your study. Second, the methodology of how you did your study, the statistical tests that you had done. These three things you need to keep it in your mind. So that is these three areas are ones I'm really emphasizing, because having been a DRNB candidate like you guys, many of us are there who would have given our thesis to outsourcing people. It may be just a statistician, or we might have given it to a community medicine person, and we would have given it to them to do the full thesis itself. So, for the exam point of view, if you have not done your thesis, please read through the things in that and then go ahead. Because if you don't know what are the contents of your thesis, it will backfire in ways you cannot imagine. So, that is one. Second, important thing is after they have gone through your thesis, they have discussed about your methodology and statistical analysis, they will ask you specifically whether you are using the results of your study in your regular practice. Please say yes. Because if you say no, the next thing is they will ask is then you do your thesis. So if that comes, that will create a very sorry face. So irrespective of whether you are using this your thesis study in your regular practice or not, if they ask anything related to that, just give an affirmation that you are doing it. Example, my thesis were related to intradialytic hypotension scoring system. So it's not that I've been using it after the thesis got accepted, but from an exam perspective, since they had asked me, I told yes, I did do it. So then they were okay, and then they left me. So this is one area I think you guys think you can tell a white lie. I think that may help in a way. So, like I said, you need to know the thesis title. The second thing you need to know about the methodology, the statistical analysis. These three areas you need to really emphasize, and please say yes. So, this is about the critical appraisal. I'll just show a small study just to give an orientation of it. I think this is the early drain study. I think most of you are aware of this. I'll just go through it very quickly because I will not go into the real contents of it. What you need to see from an exam perspective is what I wanted to emphasize. When you see this first page, delete it from your mind. Go directly to the second page. So on the second page, here itself you will have the question. This is the clinical question. So here itself you can underline it and keep it. That's lumbar CSF drainage, improve clinical outcomes measured by the subarachnoid hemorrhage. Okay. So this is the clinical question. So here in this paragraph, they would have mentioned a lot of theoretical facts first. Then they would have mentioned about the previous retrospective studies, what they would have mentioned in these three paragraphs. So mention much about this because this will not be what is important for your critical appraisal. The next is about the PICO. So for the population, here they mentioned the patient had to be 15 years, sorry, 18 years and older and present with an
Your
SAH
voice is
diagnosed by
breaking.
CT. And so this is your population. Okay. Now is it okay?
Yes, sir.
Okay. Okay. So I'll just repeat it again. In PICO, you have the population group. In population, you have patients more than 18 years presenting with acute SAH diagnosed by CT and confirmation of an aneurysm by CT angio or DSA. So this will come as your population. If you come down here in the trial procedures, usually they will mention about the intervention. So here in the lumbar drain group, a lumbar drain was placed in a sterile technique after aneurysmal treatment was done. That can be either clipping or coiling. And lumbar CSF diversion was started after a procedure, post-procedural CT scan was done. So the duration that was done was for at least 4 to 8 days. And the amount of that was taken was 5 ml per hour. So this will be your intervention. So the control is patients who do not have a lumbar drain. So that is pretty straightforward. So you have P, I, and C. Then you come down. If you come down, you have the primary and secondary endpoints. That is your outcomes. So the primary endpoint is the rate of unfavorable neurological outcome at 6 months. That is given by the modified Rankin scale. Here they mentioned about the what are the components of MRS. Please don't go through that and all. You will not have time. Your main thing is to just to see what is the primary endpoint, whether it is a subjective score or an objective score. Here they've used the MRS, which is an objective score. Then you look into the secondary endpoints. So the rate of secondary infarcts not being present in the post-procedural CT scan, that is immediately performed after aneurysmal occlusion. Then they would have mentioned the definition for that. So that you don't have to mention. Then you can look over here. They would have mentioned the Glasgow outcome scale after 6 months. Then the rate of vasospasm. Then they would have mentioned the rate of infections, include device-associated meningitis. So these are your secondary outcomes. So from based on this, you have the PICO and the clinical question ready. So that's the first part of the thing that I mentioned about. So the next thing is about assessing for internal validity. So the first thing you can read through is the trial design. So here itself they have mentioned it is a pragmatic. Pragmatic means it is a practical. Practical meaning you can apply it even to your patients. Multi-center. Multi-center, if it is there, it means that it has a good external validity because people from different geographical locations will have different biochemical and lot of variations in the body composition. So that may affect outcomes. But mind you, always see the countries that were included because here they have mentioned Germany, Switzerland, and Canada. That's good enough. But there will be some trials where they would mention 18 hospitals from Paris, France. That means it is within the same country, but they have taken different centers. That does not provide a good external validity because everything is within the same country itself. So that needs to be looked into. So parallel group. Parallel group is the conventional group that is being done. The opposite of it is crossover trials. So this is also fairly okay. So you have three good things that are there. But the bad thing starts here. It is an open label. Open label means it is an unblinded study. Thing is, from a practical perspective, doing a blinding for patients with lumbar and not lumbar is practically not feasible. But since they have mentioned it about open label, you need to mention that there is a very high probability of bias. Thing is, patients will be mostly intubated. So the heart on or observer bias is totally out. But the second one, the interventional bias is likely to occur because of the blinding not having been done. And you can see that randomization has been done. So if you see over here, the randomization is mentioned. It is being randomized using a block randomization technique. So discussing the differences between block and stratified randomization will take a lot of time. I'll personally take photos and upload it in the group. That will give a better perspective of what I trying to emphasize. So the important thing here is they have used block randomization. That is fairly good. So you can see that among all these areas so far, you can see that open label was the only bias that was present. Then you further come down and then you see the statistical analysis that was being done. In that, you need to assess the sample size technique that was used. So for sample size calculation, always see if they have taken anything from the previous studies, because based on the previous studies, they take the calculation of that sample size, then they multiply it by the precision and the possibility of an alpha error that can be avoided. Usually they take it as 85% power and 5% of an alpha error. So based on this, based on the previous studies, they come to a conclusion about the sample size. But this study had a problem with that because they had actually gone based on the LUMAS trial, but it was not available. The data was not available at that time. So they had come with an assumption that based on calculating for 300 patients, they were able to come to a conclusion that if they take these 300 patients, then the power of the study would be good enough for the results being accurate. So if they ask you about the sample size, how it has been calculated, always check whether it is being based on a previous study that was present. If they have mentioned randomly based on some numbers that they have mentioned, like over here, say that it is not very clear. That is more than enough. Then if you come little more down, you can see here that the categorical data were assessed with the chi-square test and continuous data with the Mann-Whitney U test. So these two are there. And here, if you can see, they have mentioned about intention to treat analysis was done for all patients. And in a very small subset of patients alone, per protocol analysis was used. So this, if you see in the later slides, later part of the article, you will find out that the contribution to this subset of patients is very minimal. So the per protocol analysis per se was not very significant. So I have not mentioned much about this over here. Then they mentioned about logistic regression, then about the mortality groups with Cox proportional assets. Those areas you don't need to really bother about. So then you see the consort diagram. So this is one thing I was saying. You see whether it is uniform in both the groups. So you see that 307 are there, 155 and 152. So it's almost equal. 11 were excluded, 9 were excluded. That is also good. The important thing is you need to see through the why the patients were excluded. So if you see that if anything is there that is relevant, it is good enough. But there may be some very weird reasons in few studies why they have been excluded. So those need to be taken into consideration. There was one big flaw in this consort diagram that was once the randomization was done and the study had been initiated, in the interventional group, 35 patients had undergone protocol deviations. But here only 2 patients had undergone protocol deviations. So you can see there is a wide discrepancy in these two groups. So that itself can create a bias. So that also needs to be kept in mind when you explain whether you will use the study or not. So if you ask me, I will not use it because I've already detected 2 biases. Then the next one is about the enrollment. So they said that the first patient was enrolled in 2011. But 2016 was when they finished the enrollment. They've taken 5 years. So I told you, if there is going to be a time lag, that is going to affect your interpretation of results. Even though objective parameters only were used, but the time lag being so much itself is likely to create a bias. So that is also another thing to be kept in mind. So always see the duration of study because for our thesis, it will be between usually 1 to 2 years. So that's not a problem. But when they do such a big study, it has to be within 2 to 3 years for it to be having a lesser risk of a time lag bias. So after that, here they would have mentioned a lot of words relating to the statistical significance about this interquartile range, median, and all that. Please don't waste time seeing all this. Straight away come to this one table. This will give you all the information that is being mentioned in this. Whatever they mentioned here as table 1 will be what is here. So when you see the distribution of data, always see if there is similarity in both the groups. If it is there, then you don't have to be very much concerned about it. As you can see, almost there will be maximum difference about 5 to 10 in each group. So that is fairly acceptable. Then we'll come up to the next part of it, analysis of primary and secondary outcomes. Now the trick over here is you see the p-value. Wherever you see that the p-value is less than 0.05, put a circle around it. If you see over here, there is a 0.04, then here there is a 0.04, and here below there is a 0.009. You circle it and see for which data there has been a statistical significance. So here you can see that the MRS score at 3 to 6 at 6 months and infarct at discharge and Glasgow outcome scale at 1 to 4 at 6 months. So these 3 values were significant. So you can just underline it and keep. So that will be aiding you at the end when you present it to the examiner. This is very important. Sometimes in the post-hoc analysis, they would have found something significant. Vasospasm detected by clinical means, all this and all has been mentioned. And infarction at discharge was associated with unfavorable outcomes at 6 months. So this was the secondary analysis findings that they had found about. So once you have done this itself, you would have covered most of the uh, parts of the critical appraisal. Then the next thing is about the subgroup analysis. Here they would have mentioned that is like age, sex, and all that they would have assessed, and they would have seen whether it favors lumbar drain or the standard of care. This is almost like a forest plot. The only thing you need to look is whether this confidence interval line crosses this line of unity. So if it touches or even crosses this line of unity, then it is insignificant. So you don't have to bother about it. So you see that in all of this, it is crossing the line of unity, except for modified Fisher radiological grade, that is grade 4. So in this subset of patients alone, they've shown that use of a lumbar drain is found to be favorable in this subgroup of patients. So this is about the basic idea about how to critically appraise. So what I would personally suggest is before you go for the exams, take at least one of the recent studies that has come up, like the balance trial, something like that. Practice it in the format that you are given and try to finish it within 10 to 15 minutes. So that will give you an edge when you apply for the exam. I have a small cheat code that is in most of the studies, they would have mentioned about the limitations. If at all you're totally stressed out and you don't know what to do and you don't know like where to go about it, then you just read through the limitations. In that itself, they would have mentioned at least 2 to 3 limitations in that trial. So you can just see through the limitations and then you can again read that part of the section. Like here they mention about we did not collect data based on. Yeah. Although this may be a source of error, blinded outcome assessment of radiological imaging at 6 months minimize this potential. So all this was being mentioned here. Like we had mentioned in the beginning, right? Blinding was not done. So they have mentioned about all this. Patients, relatives, and acute care clinicians are not blinded in the intervention. So if you are not able to have a clarity, you can see this and then go to that part of that paragraph and underline it. So this will give you an idea about how to critically appraise. I hope this gives you a basic understanding. My personal request is practice at least one paper before you go for the exam. Because if you do more than that, well and good, and if you have the time for it, all the more better. But my personal suggestion would be to at least practice one paper. So this is about the critical appraisal. So we'll next go to the ECGs. So for ECGs, I personally need all your participation because we'll try to finish it as early as possible, but we need to identify certain things at a fast rate so that it will be beneficial rather than being a one-sided talk. So you can either do it through chat boxes or you can tell it verbally also. So either way is good enough. So we'll proceed immediately. So when they give you an ECG in the exam, always go in a systematic format, like how we go for X-rays. You go with the rate, rhythm, axis, P, QRS, PR, QRS. These are areas where you already have an idea about. So the PR interval normal is 0.12 to zero point 0.2. QRS is 0.08 to zero point 0.12. Then ST segment, you assess for J point elevation. Then correct, you need to assess the corrected QT, that is less than 0.44 seconds, and U wave. What it signifies is repolarization of the papillary muscles or the Purkinje fibers. So this is the basics that need to be kept in mind. All of you would definitely know about it, but just for revision purposes, when you are the exam when you're being asked the ECGs, always go in this format. So diagnosis. Sorry, I think I gave the answer itself. So this one is, I think it's pretty straightforward. It's an atrial fibrillation. So you can see that that's irregular rhythm and no P waves, absent of isoelectric baseline, variable ventricular rate. So the fibrillatory waves may mimic P waves, leading to misdiagnosis. So that's one thing you need to keep in mind. Very good. At least one. There was one guy who's answered. Thank you. So the next one, diagnosis. We'll take 10 seconds. If it goes more than that, then we'll go to the answer. Please participate. It's for your exam purpose. Okay. No, actually, the answer is second degree heart block, Mobitz 2. Priyojot got it right. So I think you all are aware of this, the basic ECG heart blocks. First degree, second degree, Mobitz 1, Mobitz 2 is there, and third degree. Third degree invariably will be kept in the exam. So if you have confusion, always see at least 5 to 6 ECGs related to that, so that you have a clarity. Diagnosis. Super. It's not SVT, it's Flutter. It's a Flutter. Okay. So super. So much of cooperation is there. So basic ECG features of Flutter are: one is it is like almost like an aerocomplex tachycardia. It's regular atrial activity at 300 beats per minute. There will be loss of isoelectric baseline. You will have this typical sawtooth pattern. So that is what characterizes it. All right. So upright flutter waves in V1 that may resemble P waves. So I think many of you got confused with SVT because of that. And the ventricular rate depends on the AV conduction ratio. So this is just for identification purpose. But like I said, when the exam they ask you, always go in a stepwise manner. Diagnosis. Super. Okay. So we got the answer. It's pretty straightforward. It's in a ventricular fibrillation. So if at all you have ACLS, usually they'll have this simulation ECG simulator. So they'll keep changing the rhythms however they like. So this will be definitely one of the rhythms that will be kept. Okay. Diagnosis. Superb. Okay. Yeah, exactly. It's a Tossade point test. That's a polymorphic VT. Okay, excellent. So the important thing you need to know is patients who have a frequent VPCs are at very high risk of developing an R-on-T phenomenon that can trigger a polymorphic VT. Okay. So this is one thing I wanted to emphasize. So we have the twisting that occurs. So this is another picture that is here. You can see the R-on-T phenomenon that occurs, and that will trigger either a TDP or that itself can progress on to ventricular fibrillation. Diagnosis. Nice one. Nice try. Keep trying. Superb. I think Amarnath got it right. So this is supposed to be a image of hyperkalemia. Okay. So you need to know about the potassium levels and the ECG changes that are associated. So if it is 5.5 to 6.5, then there are going to be peak T waves. 6.5 to 7, P wave widening will be there, or they can be flattening. There will be PR prolongation, and P waves will eventually disappear. All right. Between 7 to 9, there will be bradyarrhythmias that can occur because of conduction blocks. And if it is more than 9, you can develop life threatening rhythms. So, usually, there will be pulling that will occur in hyperkalemia, pulling of all the waves. So, you can see in hyperkalemia, there will be peak T waves. The T wave will be flattened. There will be PR prolongation and white QRS. So, that is how it was there in the previous slide. So I think once you've seen this, I hopefully you guys won't forget it. So similarly, hypokalemia is like a pushing down. So you will have T wave inversion, ST depression, and a prominent U wave. Okay. Diagnosis. Sorry, that's not the right answer. You're actually the content of it is right, but there is for hypothermia. For hypothermia, there needs to be shivering artifacts and there needs to be severe bradycardia. It's not there. So that is why I put this tricky ECG. It's supposed to be severe hypercalcemia. So when severe hypercalcemia is there, that is like ionized calcium is more than 4.1, you can see Osborn waves. That is why it specifically put this kind of like out of the box ECGs. So as you all know, in hypercalcemia, there will be shortening of the QT interval. And in severe hypercalcemia, Osborn waves can occur. And worst case scenario, ventricular irritability, that VT or VF can occur. So that is the most important things you need to keep in mind. So we all know that hypercalcemia is associated with QT shortening, but in severe cases, Osborn waves can occur. Okay, diagnosis. Come on, I just discussed about it a few minutes back. It's not hyperkalemia. Gautam had told the right answer. Gautam, then Jagan Prashant has told, then Doxyazi has told. Exactly. Roshni has also told there's a U wave. So this is supposed to be a typical hypokalemic ECG. All right. Excellent. Excellent. So here you have an increased P wave amplitude, prolongation of PR. Then there is a wide spread ST depression and T wave flattening or inversion and prominent U waves that can be best visualized in lead 2 and lead 3. All right. Okay. And the important thing is in severe hypokalemia that can cause tachyarrhythmias. So if it is hyperkalemia, it will be more associated with bradyarrhythmias or conduction blocks, manifesting as conduction blocks. Whereas if it is hypokalemia, then it can go with significant tachyarrhythmias. So that needs to be kept in mind. So this is just an image I wanted to show. Patient had severe hypokalemia and then eventually developed a QT prolongation, and that led to a torsade pontus. Okay. Uh, what do we see over here? I think it is Nikita has told us W or W. WPW, yeah, correct. It's WPW, exactly. Here you can see the delta waves that are present. Okay, so this is when you like if you go in a systematic manner, you can see that the PR interval is markedly shortened. So that is one way that you can identify about WPW syndrome. Excellent, excellent, super. Okay, diagnosis. Superb, superb. That's the answer. This is a typical hypothermia ECG. See, you can see shivering artifacts that there are significant bradycardia is there, and here you can elicit J point. Okay, here it is more evident. Okay, sorry, not J point, the Osborn waves. Okay, so that's about it. So bradyarrhythmias, Osborn waves, prolonged PR, QRS, and QT, shivering artifacts. All these need to be there. Okay, so this is what. So this one, Osborn wave is a positive deflection at the J point. Okay, so this is what I wanted you all to have a look into. So you see that it's almost in sinus rhythm. There is no shivering artifact, but Osborn waves are present. Then it is highly suggestive of severe hypercalcemia. But in this scenario, it's more consistent with hypothermia. Okay. Diagnosis? Yeah, it's there. I personally would like everyone to have a look on the S wave on one lead one, then the Q wave in lead three, then the T wave in lead one again. Yeah, exactly. So that's the final answer. See, this ECG is going to be very uncommon. But since I told you about S1, Q3, and T3, my next question is going to be what is the name of that sign? Any guesses? It's called McGinn. McGinn white WHIT sign. It's called McGinn white sign. That's the other name for S1, Q3, and T3 sign. Okay. So if at all they ask you in the exam what is McGinn white, then you have to don't be very much surprised. It's just the S1 Q3 T3 part. Sorry, S1 Q3 T3 pattern that is seen in pulmonary embolism. So the other manifestations that can be there is RBVB that you had seen, and many of you had answered. S1, 2 to 3 T can be there, T wave inversions can be there. But the most important and most common finding is sinus tachycardia. So that is, if at all you get a P case, that they may ask you what is the most clinical sign that can be found on ECG. All right. Okay. Diagnosis. It's not pericarditis. Yeah, alternance is there, but what is it? Do you think effusion causes this kind of ECG, or is there anything severe enough that can produce this kind of picture? Exactly, exactly. Vinay has told, Dinesh has told. Correct, 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 correct. Okay. So thing is, pericardial effusion usually does not produce this kind of alternance picture. It is more of the tamponade because the heart keeps bouncing within the pericardium that is filled with fluid. You with each beat, the variation changes. So that produces this electrical alternance. So massive pericardial effusion produces a characteristic ECG triad of low QRS voltage, tachycardia, and electrical alternance. So, like I said, it occurs when the heart swings backwards and forwards within a large fluid-filled pericardium. So, if they keep this, please don't say the answer as pericardial effusion. It is a cardiac tamponade. All right, excellent. So many people had answered this correctly. Okay, next ECG. If you look in one of the leads alone, I think you will probably get the diagnosis. Someone has asked me a question. It's been proper. Yeah, it's not properly placed. Or is it? Okay. So this is supposed to be actually a dextrocardia. So here you can see marked right axis deviation, global negativity in the lead one, and positive that's lead positivity in AVR, and absent RV progression in the precordial leads. Okay. So that is one of the ways to identify it. All right. Okay. So if I had just put this ECG, it will not make sense. So I thought I'll make it like a scenario. So we had this kind of case actually. So there was a 24-year-old male who was a known case of type 1 diabetes. He had actually presented with sudden onset giddiness and drowsiness while playing basketball with his colleagues. So he was immediately brought to the ER and then they found this rhythm. Super. Jasmine had told the right answer. Pratap Reddy is also told the right answer. It is Brugada. All right. So you have two types of Brugada. From an exam perspective, we need to know about it. You have type 1 where there will be a ST elevation with the downsloping ST segment, whereas in type 2, you'll have a saddle back pattern. All right. Fine. Next one. No, the answer is not STEMI. Again, Jasmine got it correct. Vinay got it correct. It's pericarditis. Okay, sir, you can see there is global ST elevation that is present. Okay, widespread concave ST elevation and PR depression throughout most of the limb leads. All right, and reciprocal ST depression and PR elevation and lead AVR. And anyone has an idea what spodic sign is? If at all they keep a pericarditis ECG, they may ask what is spottic sign. Okay, no issues. See, it's just that once you have the ST elevation, there will be a downsloping of your TP segment. That may be an early manifestation seen in 30% patients with pericarditis. Okay, so it is best visualized in leads 2 and the lateral precordial leads. Okay, so that is about spottic sign. So spottic sign is downsloping TP segment. Okay, so identify the abnormality and the associated condition related to this. Sorry, no, no. Any other guesses? I don't think it's a complete hard block. No, not SAH. Okay. So this is supposed to be the digoxin effect. Yeah, exactly. Umadri Singh has told the right answer. So digoxin effect is basically downslopping ST's depression with a characteristic reverse tick or Salvador Dali sagging sign. Okay. So it is flattened, inverted, or biphasic T waves with a shortened QT interval. So this indicates digitalization. The important thing, it does not actually correlate with digoxin toxicity. It just gives you an idea that the patient is taking digoxin. That's it. So that is one of the ECGs I thought you guys should know about. Okay. Patient with recent ACS and with intermittent episodes of angina. Diagnosis. There is something very, very characteristic. Excellent, excellent, excellent. Jasmine has told, Omkar has told, it's Valencine. Okay. So this is also another manifestation of Valencine. Okay. So the first one is type valence type A, and the second one is a valence type B. Here you will see there is a typical T wave, deep T wave inversions. Here you can see there is a biphasic T waves. Okay, so that is important thing. The significance, I think most of you would know about it. Okay, so it's a clinical syndrome characterized by biphasic or deeply inverted T waves in V2, V3, plus a history of recent chest pain that has now resolved. So the main significance is it is highly specific for a critical stenosis of a LAD. So when the patient is in a pain-free state, you will find these features. But when the patient is having anginal symptoms, you will see that there is pseudo-normalization of these findings. So the important thing is you need to see serial ECGs on a daily basis in this subset of patients. All right. So among both of these, biphasic or deep T, this one is supposed to be more common. Diagnosis. Okay. So I'll just go through that image again. So you can see these images. If you actually put these images in the mirror image, you will find it almost like an ST elevation. Yeah, one guy, Dr. Rowe has told it correctly. It's actually a posterior wall MI. Okay. So it is suggested by the presence of ST depressions in V2 and V3. There will be tall broad waves, broad R waves in V2 to V3, dominant R wave, that is RS ratio more than 1 in V2, and upright terminal portions of the T waves in V2 to V3. So here you can see ST depressions are there markedly. So when you do a reciprocal reversal, you can find that there will be ST segment elevations. So here if you see the leads that need to be placed, it will be on V7, V8 and V9. So that is V7 will be in the left posterior axillary line, 8 will be in the tip of the left scapula, and 9 will be the left paraspinal region. So this will be the location of leads that need to be kept. And once you do that, you will find that the lead reverse, once the leads are placed in the posterior part, then you can see the ST elevations more markedly visible. All right. So I think two people had got it right. One is Omkar and the other one is Dr. O. Okay. Next diagnosis. Since you told posterior NMI, I think this one would be relatively straightforward. Superb. Superb. Almost all, everyone are coming with the answer. Excellent. It's not. Oh, I think one person got it wrong. It's not anterior wall MI. It's supposed to be a RVMI. Okay. Many are told inferior wall. In patients with an inferior wall with this kind of picture, you always need to suspect an RV wall MI. So what do we suspect it based on? So you see that there is a ST elevation in V1, then ST elevation in lead 3 more than lead 2, then ST elevation in lead 1 with ST depression in V2. That is highly specific for an RV infarction. So these areas you really need to concentrate. So then you need to place the leads, like how you place the leads for on the left side, you need to place it on the right side. So if you do that, you will get the images. So here you see in V4R, you will have ST elevations. So that is consistent with an RV infarction. All right. So why I wanted to make this slide specifically is you guys will definitely pick up anterior, anteroseptal, lateral, inferior. But posterior and RVMI are areas you may miss. That's why I specifically wanted to mention in my set of images. Okay. Okay. So what can you see over here? Just giving a clue. Excellent. Someone has told. Okay. L6. Excellent. 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 Superb. So I think everyone knows about the localization and areas and all. I think I don't have to emphasize on that because these are things that we've been seeing for the last 3 to 4 years. So I think you guys are really clear about it. Only things I want you guys to emphasize is on RVMI and posterior MI. Since you guys don't see that so frequently, you need to practice at least 4 to 5 ECGs related to that so that you don't make a mistake in the exam. So in any patient with whom you see there is an inferior wall MI, always in the back of your mind, always think if there is anything that is suggestive of an RVMI. All right. And similarly is for posterior wall MI. If you see that lead localization is not very convincing, always in the back of your mind, always think about a PWMI. Okay. So I think we finished about all the ECGs. So thing is regarding pacing, it may be kept either in your hemodynamic monitoring station or they may keep it in equipment. So I just wanted to give you an overview. So for temporary pacing, so temporary venous cardiac pacing involves electrical cardiac stimulation to treat symptomatic bradyarrhythmia till it resolves by itself or until long-term therapy can be initiated. So this is one thing which all of us know. So the main purpose is to re-establish normal hemodynamics that is acutely compromised by a slow heart rate. So the pacing techniques is internally using transvenous, externally using transthoracic patches, again using internally using atrial or ventricular epicardial leads that is placed during surgery or through an esophageal electrode that can be used for atrial pacing and recording also. So main indications is electrolyte imbalances, hyperkalemia or hypercalcemia, drug toxicities, post-procedural. That can be the injury to the SA, AV or his bundle fibers. During post-cardiac surgery, post-heart transplant or TAVI, that's transaortic valve implantation. Then infections like Lyme's disease, Chagas, subacute IE, that can be damage to the His-Purkinje fibers. Acute MI itself can produce this kind of bradyarrhythmias and permanent pacemaker revisions due to PPA infections or lead failure. The important thing is this temporary venous pacing should be kept for the shortest time possible because if it is kept for a long time, the infection rates are high and it can lead to infective endocarditis. That is going to be a bigger problem to deal with. So contraindications, if they ask absolutely the contraindication, there is none. But if there is a prosthetic tricuspid valve, there is a risk of injury, so preferably avoidable. But if it needs to be done, it needs to be done. And if the patient has received thrombolysis due to the risk of bleeding. So preferred procedure, you all know, preferred access is IJV or subclavian. So transvenous lead placement, only the ventricular lead is inserted. So it is almost like a CVC insertion. The only thing is once you put the dilator, you first put the sheath inside. So once you pass the sheath, you then pass the transvenous lead and advance it based on the markings on the tip of it. It can also be confirmed with ECPO or fluoroscopy. And continuous ECG monitoring is important because VPCs or non-sustained VT can occur when it comes in contact with the RV. Then it is connected to the pulse generator. So for pacemaker programming, the general mode that is kept is VOO. So that you need to keep in mind. So if they keep the pacemaker machine over there, they will ask you what are the settings that are there and how will you initially set the settings. So that is one thing you need to know about. So the heart rate usually is kept between 60 to 70 beats per minute. The pacing sensitivity is initially kept at the maximum, and then it can be adjusted between 0.8 to 20 millivolts. So if it is sensitivity, the unit is millivolts, S for V. So what is sensitivity? It is the minimum current at which the pacemaker is able to sense intrinsic rhythms. It is expressed in millivolts, and the lower the number, the more sensitive the pacemaker. We had just discussed it in critical appraisal. The lower the NNT, the better the intervention. Similarly. Then coming to the pacing threshold, it should be less than equal to 1 milliampere. So the pacing threshold is the minimum pacing output required for the pacemaker capture. So the minimal pacing output at which the action potential is generated leading to a myocardial contraction. So that is the pacing threshold. So it should be less than or equal to 1 milliampere. And the pacing output should be 2 to 3 times of the pacing threshold. So what is the pacing output? It is the current with which it produces a brief pulse. So these numbers need to be memorized. So if they ask you the sensitivity, it is 0.8 to 20. You initially keep it at max and then adjust it so that you keep it as low as possible. The lowest one which can sense the rhythm, which the pacemaker is able to sense intrinsic rhythms is the sensitivity. Then the pacing threshold should be less than or equal to 1. And the pacing output should be 2 to 3 times the pacing threshold. So the complications, it is important to monitor for all of these when the transpacing is present in situ. So lead dislodgement or disconnection, bleeding, myocardial perforation that can lead to cardiac tamponade, pneumothorax infections, catheter knotting, or air embolism. So post-procedure, if they ask you what you need to examine in that patient for, you will have to mention, you will have to assess for presence of a pericardial rub, which may be indicator for cardiac perforation. There may be presence of cardiac tamponade, which can occur. Then hypertension with muffled heart sounds is again suggestive of cardiac tamponade. And asymmetrical or absent breath sounds can be suggestive of pneumothorax. But now currently in the era where we do ultrasound guided ultrasound guided lines, it is very, very uncommon. So with regard to the 2021 guidelines on cardiac pacing, pacing is indicated in patients with bradycardia, tachycardia form of sinus node dysfunction to correct bradyarrhythmias and enable pharmacological treatment unless ablation of the tachyarrhythmia is preferred. All right. So mainly in tachybrady form of sinus node dysfunction, it is indicated, and in patients with atrial arrhythmias and permanent or paroxysmal third or high degree AV blocks, irrespective of the symptoms. So in these two scenarios, it is recommended. So coming to the permanent pacemakers, so this one is general concern. Like, why do we go with permanent pacing if there is symptoms? Dizziness, lightheadedness, syncope, and fatigue all are related to bradyarrhythmias and the location of the conduction abnormalities. Usually, if it is infrahis AV blocks or second degree morbits or third degree blocks, usually the chances of spontaneous recovery is going to be very less. So in these kind of cases, temporary pacing will not help. They'll need to go with permanent pacing. So you have class 1 and class 2 indications for permanent pacemakers. So class 1 is symptomatic brady, symptomatic sinus brady due to long-term drug therapy of a type and dose for which there is no other accepted alternative, complete heart block irrespective of symptoms, and symptomatic second degree heart block. And class 2 recommendations is sinus node dysfunction with unexplained syncope, asymptomatic second degree heart block, then bifascicular or trifascicular block associated with syncope, and post posterior, post anterior wall MI. So here contraindications are that, like if there is excessive risk of bleeding due to vascular access, ongoing bacteremia, presence of an intercardiac thrombus, or a prosthetic tricuspid valve. So these are that. Definitely, it is not an indication to proceed with a PPA. So parts of it are battery, circuit, leads, and the electrode. Okay. So the pacing nomenclature is, you can remember it as PSR, RT. Okay. P is supposed to be the pace, chamber paced, chamber sensed, the response to sensing, that is trigger, inhibited, or dual, then the rate modulation, whether it is there or not, and multi-site pacing or anti-tachycardia mechanisms. So what is rate modulation is, it uses a physiological sensor rather than sinus node, other than sinus node, to adjust the pacing rate according to the physiological needs of the patient. Like if patient is exercising, accordingly it will help to adjust it. This multi-site pacing is for anti-tachycardia resynchronization function, but it is not commonly used. This is just from my exam perspective. You need to know about it if at all it is asked. So about overdrive pacing and anti-tachycardia pacing, it creates a re-entrant pathway that bypasses the AV node or an ectopic unregulated pacemaker. So disrupting the re-entrant circuit or overriding the ectopic pacemaker, it helps it to change the pattern of the repolarization, creating more uniform repolarization. So easy to understand is, if at all there is a severe tachyarrhythmia that is occurring due to a re-entering mechanism, if you increase the heart rate more than the rate which is present, it will help to terminate it. So that is the easiest way of explaining it. So in refractory VT, overdrive pacing increases the rate of depolarization, decreasing the ventricular refractory period and reducing the susceptibility to the R-on-T phenomenon. So in AV junctional tachycardia, atrial flutter, and SVT with rapid ventricular response that fails to revert with medical therapy, overdrive pacing can be attempted. And an external electrical impulse at the rate of 10 to 20 beats per minute greater than the native rate is what is usually prescribed. So these are some ECGs related to pacemakers. So here you can see normal atrial and ventricular pacing spikes. Here you can see that there is a atrial pacing and there is a ventricular pacing. So that produces the rhythm. So two pacing spikes are there. Here there is predominantly just a ventricular pacing that is present. That is, the ventricular pacing spikes precede each QRS. All right. So pacing abnormalities. Here you can see there is failure to capture or pacing failure. This is one of the most common abnormalities that is seen, especially with the transvenous. So ventricular spikes follow the P wave, but there is no pacing thereafter. All right. Here you can see. Here the small spikes are there, but after that there is no depolarization of the ventricles that occur. So there are various etiology for pacemaker dysfunction. It can be that is failure to pace, lead dislodgement or malposition can be there, inflammation at the electrode surface can be there, battery depletion, pulse generator failure, lead maturation, or magnet application. So for most of these, the main treatment is reposition of the leads, changing the battery, changing the generator, or you need to remove the magnet if it is present. So rapid ventricular pacing, this was seen in the previous generations of permanent pacemakers. So rapid ventricular pace rhythm with no evidence of preceding atrial activity. So there are two possibilities. One is pacemaker mediated tachycardia and sensor induced tachycardia. So for that, the main management is, initial management is, you place a magnet and change it to asynchronous mode. The definitive management is reprogramming of the pacemaker. So these are the two things that need to be kept in mind when you have a pacemaker mediated tachycardia, because if it goes into a severe tachyarrhythmia, it will compromise on your cardiac output. So this is runaway pacemaker. This is paroxysmal of rapid pacing spikes at 2000 beats per minute with decreasing amplitude and rate. This fails to excite the ventricles due to the low amplitude spikes. So this also again leads to low cardiac output states. So here also you you inhibit the activity use of magnet, then you proceed for temporary pacing, and then definitive management is reprogramming the pulse generator. So complications are similar to what we had discussed previously: lead dislodgement and disconnection, bleeding, myocardial perforation, pneumothorax, infections, catheter knotting, air embolism, runaway pacemaker, and pacemaker mediated tachycardia. Okay. So what abnormality can you identify here? Anyone? LAD. But here we don't have any of the chest leads, right? Anyone else? Superb, superb. Vinay has told the right answer. See, this is basically a left anterior fascicular block. Okay. So here there will be left axis deviation. Okay. Left axis deviation is present. There's a positive deflection on one and negative deflection in area. All right. Then along with that, there will be a small Q and a big R complexes in one and avial that is present. Okay. Then you have an RS complex in 2, 3 and avial. Okay. That is also present. So these are the three important things that need to be looked into. And there will be also prolonged R wave peak time in avial. Okay. So that is one thing you can identify LAHP. That is left anterior hemi block or left anterior fascicular block. So that's why I wanted to keep this towards the end. So patient was brought in an unconscious state, intubated in ER. ECG showed the following. What are the abnormalities seen and what are the diagnosis? SCT with aberrant C. Sorry. Nope. You need to assess, like I said, go in a systematic manner, assess the P wave if it is present, see the QRS, see the T wave, see the ST segment, see the QT if it is visible. Again, no. See the question properly. Patient was brought in an unconscious state, intubated in ER. Junctional rhythm, definitely no. Any two more questions, two more answers possible. SVT, no. Trifascicular, definitely not. Okay. This is supposed to be a ECG of a tricyclic antidepressant overdose. All right. So, thing is, toxicology related ECGs are going to be very few. So, this is one of the few ECGs that are very, very characteristic. Okay. So, that's why I wanted to emphasize on this one also. So, the main things that we need to look into is QRS widening if it is present or not. Okay, so if there is QRS widening, it indicates intraventricular conduction delay. Then there will be sinus tachycardia, mainly because you have multiple receptor blockade which occurs because of PCA overdose. Here in sinus tachycardia is because of the muscarinic receptor blockade. So that causes a tachycardia. So here you can see there is a QRS more than 100 milliseconds. Sinus tachycardia is there. And the R wave will be more than 3 millimeters in AVR, and the R dash will be dominant in the AVR. So, based on these findings, you can make a diagnosis of PCA overdose. All right. My personal suggestion is, since many people are not able to answer this one, posterior wall MI and RVMI, please revise these ECGs before the exam because these may come as out of the box ECG. So this is just a basic list of ECGs that can be possibly kept in the exam. So I just wanted you guys to have an overview of this. So we have covered almost everything of this. Certain ECGs are pretty straightforward. So I did not want to cover all those aspects, but these are the ones you really need to have in mind. All right. And keep revising these ECGs before the exam. So we'll come to the last part of this. So I need volunteers for this because this is simulation based. All right. So we have a 65-year-old female, a known case of COPD, hypertension, and diabetes, was admitted in your ICU with history of cough and breathlessness, diagnosed as a case of community-acquired pneumonia, initiated on antimicrobials and non-invasive ventilation. So during the course of stay, she developed worsening breathlessness attributed to cardiogenic pulmonary edema due to sepsis-related cardiomyopathy, for which she was initiated on diuretics During your night shift while attending another patient, the nurse calls you saying that the patient is tachycardic with an abnormal rhythm. You see the patient and you see the following ECG on the multipara monitor. Okay. So for this, I preferably would like someone who would like to volunteer for this ACLS scenario. How will you proceed? If you are able to communicate it verbally, I think we would be able to finish it faster. Please don't look through your ACLH tachycardia protocols. You just tell whatever you know, accordingly you proceed. No, please don't mention it in the chat box. You can directly answer it. Anyone who's willing to give it a try, because in exam they will ask you, you will need to answer this. Okay. So I think very few people are interested in the answering part of it. Anyway, so due to want of time, you go with the AHA protocol, you assess the appropriateness of the clinical condition. If the heart rate is more than 150 beats per minute, you need to identify and treat the underlying cause. You go according to the AHA. Maintain a patent airway, assess breathing as necessary, oxygen if hypoxic, cardiac monitor to identify rhythm, plus monitor BP and SpO2. If an IV axis is already there, not to worry. If it is not there, please secure and get a 12 lead ECG. So, if there is persistent tachyarrhythmias causing hypotension, altered mental status, chest pain, signs of shock, and acute heart failure, if all these are there, you directly go with shocking, that is synchronized cardioversion. So, at that point of time, consider sedation. Airway equipment to be kept at the bedside, because sometimes when you give a shock, that patient may go into cardiac arrest. So, that time you need to keep everything ready for resuscitation. So if it is a regular narrow complex, consider adenosine. But in our case scenario, that is not feasible because the patient has a history of COPD or medical therapy. So if you give adenosine, it is going to cause bronchospasm and that is going to further worsen the breathlessness. So highly not recommended to go with adenosine. So if it is refractory, then you need to assess the underlying cause, need to increase the energy level for the next cardioversion, because this was a paroxysmal supraventricular tachycardia. The amount of joules that is needed is between 50 to 100. So you can start with 50, 75 and then go to 100. Sorry, there's no 75. You start with 50 and then go to 100. Then addition of an antiarrhythmic drug and get a expert consultation. So for synchronized cardioversion, the dosing for narrow regular is 50 to 100, narrow irregular 120 to 200. That is for atrial fibrillation. Wide regular is 100 and wide irregular is defib dose. That is not synchronized. So the next thing is, if there is persistent tachy which is not there, the next thing is you assess whether the QRS is wide or not. So this patient has a narrow complex tachycardia. So the first thing you can consider is vagal maneuvers if it is regular. Adenosine, but not in this case. Beta blockers, again, not in this case. You can go with the calcium channel blocker and expert consultation. So calcium channel blocker, if the patient is not in shock, you can go with either diltiazem or verapamil, or these are the two options that you can consider. Whereas if it is a wide QRS, then you can consider adenosine, but in this case, again, you cannot use it. You will have to go with other antiarrhythmic infusions like amiodarone, procainamide, and sotalol. So again, if it is refractory, you need to assess the underlying cause. So the most probable thing is you take an ABG. Since the patient was on diuretic, the probable precipitating factor could have been hypokalemia that could have occurred. Then they need to increase the energy level for the next cardioversion if patient is hemodynamically unstable, and addition of an antiarrhythmic drug and get an expert consultation. So this is the tachyarrhythmia protocol. I think most of you are already aware of this. You use it just for a revision. So the next one. 50-year-old male with no prior comorbidities was admitted with history of gastroenteritis. He was initially admitted in ward. In view of breathlessness, he was shifted to ICU and evaluated to have acute kidney injury with severe metabolic acidosis, which was managed medically. In view of hypertension and heart rate of 78 per minute on day 3 of ICU, your junior decided to manage with use of beta blockers and subsequently gave an alpha agonist also, clonidine. At night, you get a call that the patient's heart rate is 35. You see the multipara monitor and find the following. So how will you proceed for this? So first thing is like, what is the rhythm? Superb, superb, superb. Okay, it's sinus brady. I think that part of it is very clear. Thing is, usually they keep conduction blocks, but since these are real life scenarios that really occurred actually, so I just wanted to put these scenarios over there. So when there is a sinus bradycardia, the heart rate heart rate is less than 50, you need to be little concerned. So it's almost like what you did for tachyarrhythmias, but there will be some modifications regarding the initial part of it. So ABC, oxygen if hypoxic, cardiac monitor to identify rhythm, but most of the patients in ICU already have a multi-para monitor, but you need to monitor the BP and oxygen. IV access if it is not there, a 12-lead ECG. Consider possible hypoxia, MI, or a hyperkalemia. These will be your three top differentials to consider. And if it is a new patient who has been admitted to your ICU, always consider toxicological causes also, like beta blocker, CCB, digoxin, or OP compound. So, if persistent bradyarrhythmias are there causing signs of hemodynamic instability are not there, you monitor and observe. But if they are there, you go with injection atropine. Okay. So once it is being given, usually it actually has to come as 0.6 milligram per kg, zero point 0.6 milligram. My apologies, I've written it as one. So then if it atropine is ineffective, then you go for transcutaneous pacing, dopamine infusion or an epinephrine infusion. And after that, even with that, it is not getting controlled, then you consider transvenous pacing and get an expert consultation. So for transvenous pacing, I had mentioned uh, about it in the previous slides. So you need to know about the indications. Like I said, in the 2021 ESC guidelines, they have told tachybrady kind of sinus node dysfunction or with bradyarrhythmias, which are symptomatic. In those scenarios, you can proceed for it. So you also need to look into the contraindications. Absolutely, there are no contraindications for transvenous pacing, but for relative, you tricuspid prosthetic valve that is present is contraindicated. And one more contraindication is possible presence of bacteremia. Okay, so in these two scenarios, you need to be cautious. So oral therapies that can be tried are theophylline can be given like in the dose of 5 to 10 milligrams per kg per day in divided doses. Omkar has asked whether isoprenaline can be given. Yes, it can be given, but unfortunately in the AHA guidelines, it has not been mentioned. So if they ask about it, please don't comment it. Your top priorities will be to go with dopamine and adrenaline. That is, if at all it is still ineffective with atropine. Thank you.